Okay, let's go. Good evening, everybody. Let me. There is some noise for some microphone. Okay. Good evening, everyone. It's our great pleasure to continue our Al-Mefty neurosurgical series. This evening, we're supposed to have our dear friend, Professor Sebastian Frolich.
He's here.
He is here?
No, in my phone.
Okay. We have some technical problems. Let's see if Dr. Frolich can log in into this webinar. It's on behalf of SONESP, Association of Neurosurgeons from São Paulo, Brazil. It's a great honor to run this Professor Al-Mefty series. This evening we have Professor Sebastian Frolich to talk about management of craniocervical junction tumors. Dr. Barba is in touch with Dr. Frolich at this moment, and
no problem. You are very welcome anytime here, okay? Anytime. Yes. I will try to give some.
Yeah. Unfortunately, as we can see, Dr. Frolich cannot get into this webinar this evening, so we're gonna have Professor Luis Borba, who's gonna talk about the meningiomas of craniocervical junctions. So I hope Dr. Borba has, I hope not, I'm sure that Professor Borba has a beautiful presentation ready for this session tonight. Unfortunately, the president of SONESP cannot get into this session tonight because he's still in the OR. Professor Vega is still operating in the OR, so he cannot attend this session tonight. Let's see if Dr. Borba, please, if you can share your screen with us, it's going to be great. After the presentation, we have some time for discussion and questions. Please, the audience, you can send the questions from the QA and also to the chat. It's gonna be a pleasure to comment and to answer the questions.
Okay.
Dr. Borba.
We have a good news and bad news. The good news is Professor Frolich is alive. See, Dr. Al-Mefty, he was in surgery, recurrent chordoma. Now it's 1 a.m. in Paris. He's still in the OR. He just left. And he apologized, especially to you, Professor Al-Mefty, and all the participants here. And the bad news that somebody has to say something here. And I don't know if you should continue or if we will stop, but to have 60 people online, a lot of people will watch later on the YouTube. Maybe you could try our plan B here, that will be, you leave the French accent to the Baget accent. It will be a little bit different. Let's see you can survive this. Thank you all the participants, Professor Al-Mefty, Linda B, and Professor Coley, and all people from Latin America and from many countries that are watching this now. I don't know, Jean, continuamos ou nós paramos, cara?
go ahead and share your screen with us. I'm sure that we're gonna have a very,
Okay.
very good lecture from you.
Oh, no. You see, Dr. Gito here. Now you can go, Dr. Gito. There is no more.
You're the man.
No more good things. Sorry. Okay. Okay. You try. Dr. Froelich, you give a lecture about tumor in general of the craniocervical junction. I try to do one thing about the, let's see, can you see my screen?
Yeah.
Can you see my screen?
Yes, very clear.
Okay. Not be like Professor Froelich, but I'll try to do my best and show something about this area, the craniocervical junction meningioma. I know that there is more approach to this area than the real difficulty. Everybody take one piece of bone, give their name. We start with lateral, extreme lateral, extreme lateral, transcondylar. Now you move to the mouth. And this area, I think, is more controversy, the approach itself, the way to remove the tumor. And the controversy starts when you define the craniocervical junction. Some people show meningioma in the body of C2, close to the body of C2, foramen magnum meningioma. And some people show meningioma in the lower crivus, foramen magnum meningioma. In the craniocervical junction, by definition, and Professor Bernard George, is from the lower cranial nerves, from the jugular foramen to the superior part of C2. If you define this area as craniocervical junction meningioma, that can be completely different. The tumor that will arise in this area is different than the arise from this area. The tumor that is coming from this area is different than coming from this area. And the classification by Professor Bernard George in 2010 showed clearly what's happening with meningioma in this area. Can be posterior, can be lateral, can be anterior. The great majority of them are anterolateral or posterolateral. Can come from below, from above, or anterior to the both sides. And some approaches now, the people say that, yeah, I don't need to remove the condyle, I need to remove the condyle. I don't need to open the complete C1, I need to open C1. I need to make the transposition of the vertebral artery, I don't need to make the transposition artery. I don't believe that neurosurgery is like this. One approach for every case. One way to deal with the tumor in every case. Every patient needs his own approach, like the tailor. You should tailor the approach to each situation. You cannot do the same surgery to everybody. Now is coming a new player. I know Dr. Professor Stan here, one of the masters in endoscopy. Professor Juan Luis Gomez Amador, our friend neurosurgeon from Mexico, a master in endoscopy. Now it's coming this. I'm coming from the nose for the anterior part. If you look like this, it's very logical. See? Very interesting. See? Tumors here, you come from here and take it. Very interesting, no? But we are bringing a new player in new discussion in this area. When you go to the anatomy, you see my friend, our Brazilian Daniel Prevedelo paper, show very nice. The lateral limitation is the sixth nerve. And after that, you go to the anatomy. Look the distance between the two sixth nerves, 8.8 millimeters. But if you are using the endoscope, 8.8 millimeters looks like 20 centimeters. Your hand will be like this, big like one. If you get a tumor like this, very small tumor in the midline, maybe a nice idea to do the anterior part. But in the great majority of the time, the tumor is not like this. You have the attachment of the tumor is lateral. But if you are living in the area that I live, in Latin America, your tumor, the great majority of the tumor are like this, are large. You cannot reach from the middle time. Or sometimes like this, if you cannot reach from the nose. But if your idea for meningioma is to do a partial removal, remove a little bit and go home. Now the people are biting a little bit and send to radiation. If your understanding of meningioma is this, surgery plus radiation, partial removal and go home. If you believe that the treatment of meningioma is this way, maybe it is the way. Maybe you're not treating the patient, maybe you're treating ourselves. Why the people, when talk about this meningioma in this area, are so afraid? Why nobody is afraid of this meningioma that's coming in the cervical area? Do you know what the difference in this situation? The anatomy. This anatomy we are used to work. The tumor sometimes gives the approach for you. This anatomy we are not used to. We are afraid of the vertebral artery, we are afraid of the venous plexus, we are afraid of the lower cranial nerve. But sometimes the tumor gives the approach to you also. If you go to the anatomy, if you understand this area, the cervical spine meningioma will be very similar to the craniocervical meningioma or the cervical cranial meningioma. This was Harvey Cushing, 1932. They differentiate between the tumor that's coming from the clivus to the spine, and from the spine to the clivus. This looks similar, looks the same, but they are completely different. And the symptoms of the patient will be different also. The tumor that's coming from up to down, the patient has lower cranial nerve deficit, swallow difficulties. The vertebral artery can be encased, sometimes invasion of the adventitia, on plaque extension through the clivus. When it's going down, the tumor goes inside the foramen, the foramina. When the tumor coming from below to up, from the cervical to the cranial, is the best patient that you can get. And this patient arrive in the hospital in the wheelchair and leave the hospital walking. See, because they have compression of the anterior part. The vertebral artery in the great majority of the time is just displaced. It works like a mass effect. When you go down to the cervix, you can go extradural extension. And the results in the possibility to get a radical removal is related with this attachment in this location. How to define this? See the patient, examine the patient, see the history, you understand how it will be the approach, where the tumor is coming. But sometimes you cannot define in the preoperative exam the real attachment of the tumor. Because this you need to be prepared and use the approach that you think is selected. And to understand the approach to the craniocervical junction, we need to understand the anatomy. And the anatomy here is not complex. The anatomy here, you need to go to the lab. You need to go to the laboratory to understand the muscles, to understand the attachment, to understand the venous plexus that is around here, to find where is the vertebral artery, to find the posterior arch of C1, and you know where you are. Some meningioma from the craniocervical junction, you can operate by the midline when the tumor is going more posterior, or is posterolateral, or we're coming through to the foramen magnum. But in the great majority of the time, you need to go lateral. The decision how lateral you go depends on each case. In this situation, you have to understand anatomy. You have to prepare your approach for this. You know what's the best way to do this? I'm seeing the people go to the course and learn the transcondylar, the extremolateral, the lateral, I don't know how do you want to call. They go directly in the approach here and open the area. The easiest way is go to the anatomy department. Take just the skin, okay? And expose all the muscle and understand where is the attachment of each muscle. After you know this attachment, in surgery, it can help you. You can plan your approach with large incision that some people use, or a smaller incision as I use. If you know the attachment of the muscle, you just touch the muscle with the bovie, the muscle contract. When the muscle contract, you know which muscle is this one, you know which muscle is this one, you know which muscle is the other one. This is the way to understand in surgery the anatomy that you learn in the lab. There are some tricks you should learn in anatomy. This is the posterior arch of C1. It's sharp. See, it's sharp. If you put your finger there, don't be ashamed to put the finger. You put the finger there, you find that this posterior arch of C1 is sharp, like cutting your finger. It looks like cutting your finger. You know that it's this. You know that vertebral artery will be here and will be down. The trick to find the triangles, see, you find the transverse process of C1. You know one muscle go up, one muscle go down, you'll be the triangle here. In the middle of the triangle, the great majority of the time you have amount of fat, some vein around, surrounding the vertebral artery. But when you know the anatomy of the muscle, you just open and dissect it. I know that surgical position, as every position the position is very important, is a matter of choice. Some people like one position, some people like another position, some people feel more comfortable with the position. I'm not comfortable to do sitting position, but I know great neurosurgeons like Professor Campero, that the people in German, they used to use the sitting position. And they feel very comfortable. It's good. It's good. It's cleaner when you do the sitting position. The blood go down and the field be very clean. I don't feel so comfortable. I prefer to do the true lateral position. I know that Dr. Al-Mefty just rotated the shoulder a little bit, but I know, Dr. Al-Mefty, you almost do lateral position because you move a lot the table laterally. See, it looks like a lateral position. You move the table. See, I prefer to do a true lateral position, but there is one problem here that I have to tell is this here, the shoulder. If you have a short neck, the shoulder will be a problem. What I do, I put the shoulder, I push anteriorly and down, see, to expose the area here. And this muscle here, the trapezius and the sternocleidomastoid muscle, has to be very tight. Sometimes the guy from monitoring say, "Oh, you're pushing too much." Okay, if you have this, sometimes you have to adapt. Do you know why I use this position? Because in my head, my mind, it's difficult to me to rotate the head because you change the position of the vertebral artery. And I like this position, or straight like this, or 30 degrees, or totally see. I don't like to rotate it. I'm seeing so crazy position that the people go around and do S-shape incision. I saw one incision like this. I've never saw in my life. Everybody want to be famous, you know, Dr. Al-Mefty. And everybody change a little bit and put their name. See? When I do like this, I came the incision, the thing. The center of the incision is in the tip of the mastoid. Okay? And it's coming from this part here. When I do a retrosig, the center is the external auditory meatus. We identify the sternocleidomastoid. Here is the superior, the greater auricular nerve. When I go intradural for meningioma, the sternocleidomastoid go laterally. You see? This is the sternocleidomastoid. You pull in this direction here, have to cancel the attachment here. This is the mastoid. Now, the splenocapitis. The splenocapitis is come back, see? And longissimo capitis will be there. You identify the occipital artery. In the end, it will come back. Because this is very important to keep a small tuft of muscle here you can attach back. See, here's the longissimus capitis. Now you find C1, the transverse portion of C1, I have a triangle. Superior oblique and inferior oblique. The superior oblique you put lateral, and at the end, this superior oblique will go down to help to close the dura. It's very difficult to close the dura here, no? I have I have one picture that I close very well, but it was just to show the movie. See how far the sharp way identify totally the vertebral artery. In some situation, you need to transposition. Some situation, you don't need the transposition. When you see in the pre-op exam, the carotid artery is involved in the vertebral artery, it's good to do this. You see the joint, atlanto-occipital joint. Now you do the craniotomy in the posterior fossa. You expose the posterior fossa. See the vertebral artery put down. I open the transverse foramen there and liberate the vertebra down. Okay. The sigmoid sinus, you don't need to go too lateral. And now start to remove the condyle. How much to remove the condyle? I remove when I see that it's plain, that to start to make the round like this. When I see that it's completely plain, you can stop. When you do this, stop this area here. Here the jugular foramen. Here is plain. Remember, I'm in lateral position. You see, you have this area like this. Let's show a case like this. Spinoclival meningioma. Looks like, see, you could come from here, no? Look, the spinal cord here is push lateral, contralateral. The tumor is giving the approach for you. But if you come from lateral, in this situation, I liberate totally the vertebra, see? I need to do this? Maybe not. But look how nice it is. How here is the anterior part of the jugular or the foramen magnum. I'll go directly to the attachment. I can go to the superior part and see how the attachment of the tumor from the cervical part to the cranial part. I have the distal vertebral artery, have the proximal vertebral artery, and the whole body is, the whole tumor is here. You can take like a ball. You can, or can decompress, make smaller, and remove. But this, the plan was so nice, I could get it and do this. But the most important thing, go to the attachment of the tumor. But this was a spinoclival meningioma. It's not the one that is involved in the nerves. It's completely different. This case, very interesting. You see, but this case, I need anterior approach. I need or anterior, very nice, see? Or here. But what we did? Look the anatomy here. Look the angle of C1. Look at the angle of the foramen magnum. Look at the size of the foramen magnum. See? How big is this area? We did a very simple approach. Coming from lateral and direct to the tumor. The tumor was coming out here. Who made the approach to me? The tumor and the anatomy. Because this is very important in the pre-op to have a CT scan. CT scan to show the bone anatomy. You know the angle, you know how much bone maybe you need, maybe you don't need to remove. Sometimes you do the approach, you prepare to not remove the condyle, but you need. Sometimes you prepare to remove the condyle, but you don't need. Another situation like this is different, you see? I need to go to the other side. The spinal cord is here, the brain stem is here in my brain. I have to come in more lateral. I have to come from here. It's easier because I need to see bilateral vertebral artery. In this situation, I need to go more. But when you decide how much you decide, in the time, because this, the muscle dissection and the position is important to do a standard way. The bone removal is case by case. Another case very similar to that, spinoclival. We did the same situation. You dissect like this, and the tumor will come. Cut the attachment there. You liberate totally the vertebral. When you liberate the vertebral, you can mobilize the vertebral. Medial, lateral, up, and down. Here's the 12, see? Who is shaking, you see? I was trying to clean the tip. You see, you can remove also the dural tail, the anterior part like this. Who made this to me? The tumor itself. The approach helped a lot. If you have a good approach, you can be prepared for any kind of situation. All of us that used to work in this area know that sometimes every case is different. Sometimes you need to do more, sometimes you do less. And meningioma is crazy because sometimes you open there and the tumor come out very easy. In other situations, it looks like easy, it's tough to remove. But you need to be prepared. See, we cannot decide the time that, oh, now I have to come back and open more muscle to dissect more lateral. If you do this and prepare in advance, it will be easy to you. This is the worst case that you can get, is the reoperation, redo. This is the patient was operated 5 years ago. They removed part of the tumor. Now the tumor is back. The patient had a very slight dysphagia in surgery before. I did the surgery. I removed the part. See the vertebral artery, immobilize the vertebral artery here, but there was no plane around the artery. You see the color that you can get? See the vertebral here, proximal and distal was working. One day, one guy said to me, "Oh, you should go there and take this vertebral artery out and do anastomosis." Oh, very nice. Okay. Today, to do bypass is the easiest surgeon in the world, and nobody has complications. Very interesting, very interesting. Too many bypass, too many bypass. In the end, you have like this. You remove the mass. There is tumor around the vertebral artery here. I think there is something. But you can follow from the superior part, from the inferior part, and follow that. What's the most difficult situation here? To close. The previous surgery, I couldn't get the same flap. This patient had fistula. I kept, in this case, the long time, the lumbar drain. And after, she needs a lumboperitoneal shunt. This is the pre and the post-op. See? She can, the vertebral, you see? And it's post-op, not pre-op, okay? Trust me, okay? And the pre and the post-op. Another situation like this, you just follow the tumor. You know what's the most difficult part? This part down. I couldn't follow down. But here, you can follow from up, from down to up, just following the tumor and following the anatomy in lateral position. In the pre and post-op, see, preservation of swallow. Not go too fast. Oh, swallow is okay. Let's stop the video before the patient has problem. It's okay. No, see, you can get a nice thing. Some situation for me is difficult. Is a guy has just diplopia, tumor in the superior part. It's not a real petroclide, it's a tentorium meningioma, taking the posterior part of the cavernous sinus here, but more tentorium, and another tumor in the jugular foramen. But the patient had no deficit or lower cranial nerves. I went to surgery, I did surgery, I removed the superior tumor, and the inferior part was difficult to me. And I decided to leave a small piece of tumor inside the jugular foramen because I couldn't find the plane between the lower cranial nerve, the jugular foramen, and the tumor. Now this patient has 90 years follow-up. He's a man from Rio Grande do Sul. See? And the tumor is still there, very small. The swallow is okay. The voice is okay. The patient is going very well. No radiation. If the patient starts to have deficit, if this patient is completely deficit, maybe I can go there and remove because you compensate with the other side. If the tumor starts to grow and the patient has no deficit, maybe it's a good indication for radiation therapy or radiosurgery you want to call. This is another case, same situation, tumor there. See, I couldn't find the plane very well. See, for me, it was too attached to the nerve. See, it was difficult to me. I couldn't remove perfect. I prefer to leave a small piece of tumor and follow. Acute lower cranial nerve deficit is the worst complication. Acute means gastrostomy. Acute sometimes means tracheostomy. If the patient has deficit in the pre-op, they adapt it very, very well. Another situation, complication here, the patient had homolateral 12, wake up with bilateral 12. Man, so it's terrible. The tongue is important for many, many things, you know? It's important. In my age, it started to be very important also. And the tongue, this patient had bilateral tongue. 1 month in the hospital, could not swallow. The lower canal was okay, but they couldn't swallow okay. You see, fortunately, after that, she recovered the contralateral deficit, and she could recover the ability to swallow. But lower canal, the 12 also is a very, very important. Another thing that the people always ask when they talk about this is craniocervical stabilization. In the great majority of the time, you remove 25% of the condyle, maybe a little bit more, no more than this, just to have this view. It's different when you do chordoma. It's different when you do rheumatoid arthritis or other kind of. For intradural lesions, like meningioma, I never had a case that I need to fixate, to need a fixation. But for chordomas, it's very common that you need. And the idea to do the fixation is not just unilateral. You should fix the whole craniocervical junction. Because if you fix unilateral, the other side will still move. It may be you can have complication. I remember this is a serious point. When I was in Little Rock, Dr. Al-Mefty was a cover of the Journal of Neurosurgery. Very nice, see the fixation, very nice this. But this patient has a high possibility to fail when you do unilateral. Today, we prefer to do bilateral to stabilize completely the craniocervical junction. When you do unilateral, maybe you need to keep the patient in the halo for long time to fix the situation. Now I spoke too much. I think it's the end. Our meeting was in 20, moved to 21, moved to 22. One day you have the meeting in the beautiful city of Rio de Janeiro. Thank you for the opportunity to talk to you. I hope you're not so boring, but we miss Professor Froelich. He'll come back. He'll come back soon to give a lecture to us in the Al-Mefty series. Thank you, all of you. Thank you. Paulo, Jean is here. Paulo is here. Everybody's here.
Yes, thank you, Professor Borba, for this once again great talk. I would like to invite the audience for questions. If anyone has questions, if the panelist has questions, we can start with the panelist and then we can move to our audience, please.
Not question, comment. Everybody talk about this. The way they do it. Not question to me.
let's start as always, as usual. Professor Osama Al-Mefty, please. We need to hear you.
Well, if you start by me, you will give no chance for anybody else. I'll take the time.
Go ahead first.
Professor Borba, thank you like always. Informative, thoughtful, experienced, beautiful, and very motivating and inspirational. So I sure thank you. And I want to hear what the other people will contribute and comment. As you could tell that I always have some different thoughts, let's put it that way.
Go ahead.
And one, it's a kind of, you're always the prisoner of the last case you did. Whatever did not go just right in the last case, you will never forget it. And this, I want to emphasize again and again that no matter who's your anesthesiologist, no matter how small or big the tumor, no matter what the patient deficit or the absence of deficit, extreme neck movements with the lesion at the foramen magnum could by itself be disastrous. So I think that two more difficult moments in this is intubation and positioning. So do you always do awake endoscopic intubation? Do you fix the head during the intubation? And that's one. Two, for positioning, and I think that is the most dangerous moment next. Do you do all the positioning under continuous monitoring? At least if not more on SSCP, SSCP at least. Frequently, we, with the larger tumor and the compression at the cervical medullary junction, you could see, but just by putting by the tongues, like somebody SSCP change, and when you neutralize it again, you will reverse that. And that's why no head rotation at all. Head rotation, in addition to what you described, that it deform the anatomy, especially the course of the vertebral artery, it does contribute to a movement at that level that might lead to a compression. So I believe in all the foramen magnum lesion, the head and neck should be totally neutral. So now you're achieving that with the full lateral position. The full lateral position, like you said, the shoulder is in the way. I always did the head and the neck and the body is neutral, and just rotate 45-degree the whole thing, not complete lateral, not supine with the head rotated, the whole body log roll, we call it, 45 degree. So I agree with you, no head rotation. Head rotation, no good. You need neutral rotation. But you gotta get that shoulder out, and probably full lateral will keep that shoulder in the way, especially on the right side if you are right-handed.
Yeah.
And especially like you said, if the patient has big shoulder, and worse if he has a big shoulder and short neck.
Yeah. And I think the monitoring in this area is crucial from the beginning, not for the intradural part. See, before intubation, before put in position, is essential the monitor to be aware that, because it's in this part, this time, sometimes you lose the patient. Sometimes you have complication from the position. See, this is a crucial point before you put in position. See, the idea of when you go straight like this, the shoulder big like this, we are trying to move the shoulder anterior, but keeping the anatomy lateral there. See, not the neck is totally flat, but the shoulder is more there. The problem is not when this short neck like this. The short neck don't have space to work. See? Maybe in this situation, the sitting position will be better. That you come from lateral here, you can take the shoulder down. See? But I agree totally, Professor, that in the intraoperative monitoring is essential from the beginning. It's difficult that sometimes they start the anesthesia before you put the monitoring. I think the idea, you just sedate the patient, leaving his position, complete monitoring, and start to move with this. I never saw this with meningiomas change. See? But I saw this with the cervical compression. See? 15 days ago, I did a anterior compression of the cervical spine. Yeah? And when they start to intubate, the SSP went down. When they move back, recovery. But it's very dangerous situation, very dangerous situation. And before the monitor, in Brazil, you still have problem to the insurance sometimes. And the government is more difficult on time. You cannot get the intraoperative monitoring. I believe today that skull-based surgery in general, you cannot do without intraoperative monitoring. Any part. See, not only the craniocervical junction. See?
How practical to do SSEP before they are in full anesthesia? I just don't have experience with this.
No, before to put this, because
Yeah.
the full anesthesia, before intubation, I say this. You sedate the guy, you monitorize. Just to put this in. When you complete the anesthesia to intubate, he is
Then the
completely
SSEP.
monitorized. See? It's not before, no. Like baseline, you need baseline. Have the baseline. When you move the head, move the neck, you can get this. You see this in trauma. In trauma, you see a lot like this. See? And I believe there's a lot of patients, cervical spine trauma, and Dr. Andre here, and Dave Joaquin is here, we can say more about that. Before monitoring, cervical spine trauma, many patients was hurt by the surgical position. Andre, what's the percentage, if you know, of the patient with cervical spine trauma had deficit by the position? You have some data like that?
Well, actually, I don't have the exact information. In my experience, especially in basilar invagination, we have some monitoring chains before position. By this reason, we generally get the potential before position, after position, and after start the surgery. We have two cases that the potential was okay. We positioned the patient, it was completely okay, and just before we start the incision, the motor potentials drop. And by this reason, it's not only immediately after you position that you have to get the potentials. You have to get it during before you start the surgery. We get it again because it can drop. It's like it's continuous. It's not exactly when you position. It gets some minutes later. You can have some fall of the potential. So by this reason, we talk with the anesthesiology, and before we flip the patient, we get motor and sensitive potentials for very unstable cases. And this is true for trauma, not only for congenital craniocervical malformations.
Dr. Borba, tonight you have such a great panelist team here. So let's ask. I would like to invite Professor Armando Basso from Argentina. who certainly has some comments about this this lecture. Professor Basso, are you here? I can see you from here, but I cannot hear you. So
Dr. Guinto, Dr. Guinto is here.
Dr. Guinto also is here. Dr. Enrique Osorio also is here.
Yes, sir.
Please turn on the
can I-
camera.
Well, first of all, of course, a wonderful lecture as usual. Luis, excellent presentation, beautiful cases, too educational. Thank you very much. I have a couple of questions for you. The first one, we saw that you do the opening plane by plane in the muscle layer. Do you do this in the patients? Because I used to do it like this, but you create some dead spaces between the muscles. And I just make a skin incision up to the lateral mass of C1. And then with the microscope, I used to search for the vertebral artery. And the second question is, what are your tips about the management of the venous plexus around the vertebral artery that sometimes is very huge and it's very difficult to control? Just to mobilize, if you need to mobilize the artery, it's very difficult with this venous plexus. What are your tricks that you can tell us?
Okay, about the muscle, when I start, I was doing larger incisions. See, larger, was big like this, and we're going muscle by muscle. Okay, now I do 2 layers. One layer is the sternocleidomastoid, and the other layers are the other muscles together. I agree with you. I agree with you. That is difficult, and sometimes have a big collection like this. For me, sometimes it's difficult to find the anatomy well to dissect the vertebral artery when you do a straight incision. But I think it's okay. You have much less, that's a big collection of fluid. When you do the muscle by muscle, you have more. But I think I don't do muscle by muscle. I do 2 layers. One is sternocleidomastoid, that's coming anterior, and the other muscles are coming medially. It's coming the splenocapitis, the longissimus capitis, and the inferior oblique. It's coming in one big mass. See, but I agree. If you can do straight, you have much less collection. But I don't feel comfortable with the anatomy when I do straight incision. But I think I completely agree with you. The other thing that's very important point is the vertebral artery. When I start, we didn't have fibrin glue. Okay, was Surgicel, was very difficult, bleeding like crazy. Okay, after came the fibrin glue. Inject around the artery in the plexus, very nice, no bleeding. Until I opened the dura and had a tumor by a fibrin glue. I inject extradural around the vertebral, and this glue went around the vertebral to intradural part. Now, what I'm doing, I'm injecting. If you start to, I was doing prophylactic, you know, prophylactic. When I identify the vein, inject there. Oh, was perfect. Now, what I do, when bleed a little bit, I try to pack, to coagulate, wait a little bit, and just a little bit of glue. I'm afraid of glue. Afraid of glue in 2 situations. One is here when I saw another tumor intradural, a tumor made by glue. And another situation is the superior petrosal sinus. I had a terrible complication that I never forget. I will never forget. I was doing the petrosal approach. Nice. Identified the superior petrosal sinus. In the inferior part, I coagulate, start to bleed. And I inject a little bit to the anterior part. They had to go to the cavernous sinus. Good. But was bleeding in the back. I inject just a little bit. And the glue went to the sigmoid sinus and occluded totally the sigmoid sinus. I know that the people say good thing that the glue, you can do everything. You can dissect the cavernous sinus, there is no bleeding. You can dissect every area, there is no bleeding. I think the fibrin glue is good, but less you use, safer will be. You see, I think the way that you treat this vein here.
One more trick is the position of the patient. I mean, the head has to be up in the upper position and the chest in the lower position, so you can control much easier the bleeding, the venous bleeding.
Yeah. I do like almost sitting, you know, working like this.
Inverted
Sometimes I'm
inverted tremendous. Yeah, it's very
yes.
important. Yeah.
But I'm afraid sometimes that the patient is held by the clamp here, and the body go down. Maybe the head will out from the neck.
Thank you.
I can
I
see.
know Dr. Al-Mefty move a lot
Yes.
the table.
I can see
Yeah.
Dr. Al-Mefty turn on the camera. Please, Professor.
Yeah, I'm glad you brought it up, Professor Ginto. I don't have a bleeding from around the vertebral artery. I totally believe in what Dr. Arantovic has found, that there is a enormous plexus sinoidal around the vertebral artery, to the point he called it the suboccipital cavernous sinus, with a beautiful dissection. The paper is out. What I learned from this, that you gotta stay out of it. Those veins are so difficult to stop bleeding from. So the only way to really stop the bleeding is never get into them. That means when I position the vertebral artery, and I very commonly transposition the vertebral artery, maybe a little more liberal than other might be. I keep the areolar tissue. There is fat, there is a little muscle, there is a little fibrous tissue around the vertebral in that place. So I stay outside. I stay outside to the point that instead of putting a vascular loop around the vertebral and pull it out, I could put the stitch in those tissue around the vertebral and pull it out. Stay out of it. Keep the whole plexus with the fat and the areolar tissue and whatever around. You don't need to see the adventatia of the vertebral to dissect it and mobilize it. You just mobilize and block all of that tissue around the vertebral. And otherwise, you've got to have a bleeding and bleeding and bleeding. And I caution, like Borba said, from injecting of the fibrin glue, we did have and reported some problem with the injection. It's an art by itself, like he said. If you ended injecting, you gotta inject very, very little under low pressure. Otherwise, it will move on to a more serious vein. Now, the problem with raising the head, then you got into the problem of air embolism, increased risk of air embolism. Now you have a wide, big veins open and you have the head elevated, then you have to risk of, or increased risk of air embolism. And you have to take all the percussion of air embolism. But if you just leave those tissue around the vertebral, don't dissect them. You don't need to see the vertebral adventatia. They want to bleed, and if they bleed, you could compress it, fat with plexus of vein with some gel foam over it, and will stop it. I feel very strongly about this, that you could minimize the bleeding from, otherwise it will be terrible. Those veins bleed and bleed and there is nothing stopping them. Is by leaving the tissue around the vertebral and mobilize the vertebral with them in one block.
But sometimes bleed.
Yeah, they bleed.
Yes.
But remember, it's a venous bleeding, and it's stop with some compression, and usually with Gelfon with the glue.
There is another vein there, the posterior condylar vein, but it's very easy to control with gel foam, and that's it. That no problem. Mm-hmm.
This vein is sometimes you can dissect.
Yeah.
Sometimes. Yeah.
Oh, that one could bleed on you enormously because it's big and coming from the jugular bulb directly. Till you understand that that's what's gonna do. So instead of stopping when it starts bleeding, you drill all of that foramen really well and plug it with bone wire. You gotta separate it up, get to that foramen. You gotta finish the drilling over it to really plug that foramen.
Very good.
Thank you.
Dr. Gomez Amador, you were cited by Dr. Barba during the lecture, so you have the chance of giving some insights or comments, please.
Yes, sir. First, as always, Professor Borba is showing us a precise microscopic dissection that allows him to take out the tumor in blogging sometimes. But let's put the endoscope everywhere. So at the beginning, the training is in skull-based surgery, not in endoscopy or microscopy. But we need to recognize that now a lot of endoscopic skull-based surgeons are leaving out the meningiomas for the endoscopic endonasal treatment. And this is because several reasons. In the first place, working at the very end, I mean, the most anterior part of the anterior fossa and the craniovertebral junction, it's very difficult to reach through the endoscope. Particularly in the craniovertebral junction, the nasopalatine line defines a group of patients that may have an endoscopic endonasal approach to treat those lesions, and some other patients that it's impossible. And if I do an anatomic study in this region, it will be very nice because I will have all the time to make a precise dissection using very large tools and sometimes using angle endoscopes. Working with an angle endoscope is more difficult. It's more difficult than we do with the 0 degrees endoscope. So we need to learn that is it possible to treat those lesions with endoscopic endonasal surgery? Of course, yes. But we need to acknowledge, is the patient going to have a benefit from this approach? Is it better? Can I achieve a Simpson 1 resection for this meningioma? As we saw in the videos of Professor Borba, it is possible to reach from side to side all the anterior margin of the foramen magnum through a lateral approach and with a precise control of the vertebral artery. I think now, in these days, meningioma is no longer a precise indication for endoscopic endonasal treatment. And we have precise techniques that allows a perfect treatment without putting the patient in risk. For example, I come to the anterior approach and I find that the vertebral artery is completely encased with a tumor. It's very lateral for me to the anterior approach to make a precise dissection of the tumor, that region. And this makes that the patient is in danger. So I think we need to use the tools that we have in a proper condition. I remember Professor Sebastian Frolich with a very complex case in this region, and then he's using a lateral approach and using the endoscope to look at the other side, but using the intradural inspection with the endoscope, no with an anterior approach. I think this region is very difficult to reach. There are a lot of anatomical descriptions using the far medial approach, etc. But I think the results are not as good as with the standard techniques.
Thank you, Juan. I can see from here that Dr. Enrique Osorio is with us tonight, so it's a great pleasure to have you. Would you like to make any question or comments? Please turn on your microphone.
Okay, thank you very much. No, I only want to say that I enjoyed the presentation of Dr. Luis Borba. Very nice technique. And really, I don't have nothing to addition to the wonderful talk of Luis. Thank you.
Many thanks. Professor Roberto Leal, I can see from here that you're very, very moving and you're excited to make questions and comments, please.
Yes. Good night to everyone. Oh, and I'd like just to do a contribution about the position, the discussion about the position. I use this.
Roberto,
Yes. Yeah.
can you share your background screen? Can you share
Yeah.
this screen?
No, but
your background.
I prefer use this screen in my background. It's better.
No. We want to see better. We want to see better. You have a crazy position there. One is lateral, totally lateral. Let's see. Very nice there. Can you share this?
Yeah, I will try.
Go ahead.
Let me see here. Play. Can you see this?
Now we are in trouble.
Ainda não. Aqui na borda de baixo ali, o verde, share screen. Clica lá.
Ok.
Aí vai aparecer todas as suas telas, escolhe o que você quer compartilhar. Agora sim.
Yes.
Yes. No, I commonly use this position. No, the head stay in lateral position or 3/4 prone, and the body goes in 3/4 prone. So, especially for the right side approach, you have some space here to put your arm and work here. No, the shoulder is going 3/4 position, no, and the head stay in normal position. Here's just another, like Borba showed, no, a true lateral position, and this position here. But I would like to highlight this one, no. No, I move the shoulder, no, to the opposite side. No, it's very comfortable here. You can rest your hand here, your right hand, and work here, no.
Where the surgeon stays in this position?
Where?
Where the surgeon, where are you?
I stay behind the head, no?
Okay.
Lateral. And I have another position, but that's the true 3/4 position, no? And this one here, but I got this from the. It's no. I prefer.
This is for
No,
Magna like that, or for
no. I'm showing for retro-sig approach, but you can do the same, you know. Here is for the retro-sig approach, you know. But you can use for you just modify you change the incision, and you can do for a magnum. But here is for retro-sig, no. I'm just highlighting the shoulder. No? That was the discussion before. No?
I do the same with the shoulder. Put the shoulder here. The different, I don't move the head like you are looking down, you see? Your face is looking down. For me, the face is looking straight.
Yeah.
Directly here.
But you showed the shoulder was straight. No, now
no.
Maybe I got confused. No.
No. The shoulder is here. You pull down. Let's do this. Okay. I learned this now, Dr. Jean. See? Look at this. Okay? The shoulder go down and here. You put the shoulder this direction. Oh!
Don't see your screen board, but put your...
Yeah, I clean now.
Are you
the
drawing?
shoulder? Yes. I learned the new
Very
tool,
nice.
the Zoom now.
Okay, just no small contribution.
Perfect. Thank you very much. I'd like to invite Professor Benedito Colli to make comments and questions. Please, Professor Colli.
Good night, everyone. Thank you very much, Dr. Borba, for your lecture. I agree with Dr. Al-Mefty. Leave the vein plexus intact. It's better. I rarely cut the dura for mobilize the vertebral artery. And normally, if the venous plexus bleed, a small piece of gelfuan and some compression is enough for controlling the bleeding. Boba, I have one question for you. What's the landmark to consider what is interlateral and posterolateral?
Why? The tumor?
Classification of meningiomas, yes, of the foramen magnum. What's the landmark?
They say that is the dentate ligament.
Dentate ligament.
With the posterior and lateral. But
yes,
the great majority of the time
in the MRI,
extension of the
you
tumor.
can distinguish.
No. It's
Okay.
in surgery.
Okay.
The difference in the MRI when you see the tumor. See. Let's come here. Okay. Let's see. Oh, I cannot find here again. I want to show you the position that is. Let's see if you can open this fair. What's make the approach, see, is more anterior and more posterior. If the tumor is more here, the center will be here, maybe you could make it come to here. The posterior lateral is coming like this. Know what I mean?
For me, both figures are similar.
Maybe you should ask Professor Bernard George.
Yes.
And he said that's different. Maybe you should ask him. He's still working. Maybe you can send the question to him. Where is my screen? I lost my screen.
Yeah.
He published it a long time ago.
Let's hear the young generation. I'd like to hear Dr. Márcio Hassi, who has spent a lot of time with Dr. Borba, a lot of time with Professor Al-Mefty. He could taste different generations, and I'd like to hear from you, Dr. Márcio, your thoughts about these tumors.
Thank you, Jean. I have a question, but it's not really related to specifically to meningiomas.
Ask to me,
really
ask to Dr. Al-Mefty.
I'm asking to both of you. And not to all panelists. when you have a tumor that you have to remove a lot of the condyle, and eventually, if it's a bone tumor as a chordoma or something, then you already have some bone eroded. Is there, how can you tell intraoperatively that this patient might have instability? And when you realize that this patient might get instability, what's your next step? Do you, in the same surgical time, do you put the halo vest, or do you do a CT or something first? Do you put just a neck brace, a collar? How do you proceed after surgery? I mean, you finish surgery and you say this guy is gonna have instability. What's the next thing you do?
For me?
Whatever.
Dr. Al-Mefty, please go ahead. You still there?
Yeah, I'm here. I'm always there for you, Borba. You could throw the ball to me anytime you want to. I will get a goal.
I know your answer, but go ahead.
You pass the ball and I will get a goal. Don't worry. It's a beautiful question, Marcio. Like always, you're thoughtful and worry about the important things. I tell you my own practice, which is hard to duplicate, especially these days in many places. Number one, in a benign tumor, and you're removing the condyle for approach, you're resecting part of the condyle. And as long as that resection remain up to the 12 nerve canal, the remaining part of the anterior condyle on one side is adequate, and these patients do not have instability and do not need any stabilization. So the question really comes in malignant or bony destructive tumors, which the most common one in that area will be the chordoma. You could add chondrosarcoma, you could add the chondrosarcoma of all of its kind, being low grade or higher grade. You could add metastasis, etc. But the most common will be chordomas. In chordomas, you will be removing, and you know that in advance from the CT scan before the operation. So these patients need stabilization up front. You know that. So I plan my surgery that this patient is gonna get a stabilization. Now, in many time and in my experience and in contrary to what Dr. Borba said, we did the stabilization on one side. And there was a failure, and those failures were mainly in the children, where the ligament in that place is more relaxed, and unilateral fusion was not adequate in children, especially the children with the congenital anomaly in that area or have Down syndrome. They have lax ligament. A unilateral stabilization was not adequate enough. But in adult, I have no hesitation to do unilateral stabilization. And if you get a good construct, that good construct is enough that you could take, you don't need any additional support. You might put them in a Philadelphia collar for a little time for comfort, but that's about it. Now that's different than what Borba said. And then I would want to hear what led him to what he's advising. Now, for me and for many years, because I want to stabilize the patient while still in the operation and their sleep. So those patients with chordoma, which I know they're gonna need to be stabilized, I put them in a halo before the operation, and I operated in them in the halo. So they will remain in a neutral position. So they will be fused in a neutral position. Now that was the troublesome because you have to cut the halo and open it from one side, etc., till another smarter Al-Mefty came by, and that's Keith Al-Mefty, and tell me, don't worry, I will fix them with the tongue and the traction in a perfect position. You don't need the halo. And we did. So I think in those cases, they will be positioned under fluoroscopy exactly like you're gonna fuse them. Now, I just told you that my patient is inclined 45 degree. He's straight, but inclined in 45 degree. That position changed, or most of the spine surgeon at least are familiar and comfortable with the straight back trajectory. It's hard for them to imagine how the screw goes in the C2 pedicle with the patient in 45 degrees. Now, but the anatomy is open up there. You're seeing where the vertebral, you're seeing where the pedicle on one side. Another side, I don't know, these days there is also the spine navigation. For me, I put that screws in the C2 pedicle in 45-degree log position. Now, when things come in this, remember, it's nice to put the screws in the C2 pedicle itself, but sometimes the C2 pedicle is really narrow. And in that area, it's enough to put intrafacet screws, and that will hold enough for a good construct. Because remember that your mental construct, and I see Professor Tanaka up there, Koji High, he will correct me. That mental construct is just to give time for the bony fusion to take place. You gotta put a real good bony fusion, which I take the ribs and put construct to occiput to C1 to C2 to get a good bony fusion. The last but not least in this, if you are in a place where you have the beautiful cooperation before your team, and your spine man is very eager to do the fusion, and you will like very much after 12 hours of working on the chordoma for somebody to take over, okay, then they're familiar with the prone. They turn the patient back to prone. They very much all the time believe what Dr. Borba said, that the fusion must be bilateral, and they do bilateral. I cannot help it here, but to add one more thing. The occiput in old and young, and especially in the young, are so thin that what you have in industry, screws come from outside to the inside, It usually penetrates the bone. It could penetrate the dura, and it's not strong enough to hold. And that's why you could find that technique. We long time ago designed, and Dr. Pate has taken a leadership into this. It screws off the occiput to come from inside to the outside. That will hold the whole occipital bone. Unfortunately, it never been made available commercially.
Very good. We have a couple of spine
may I say
guys
something
here.
here?
Yeah.
Deixa eu falar aqui,
Yes, sir.
Yes.
Go ahead.
Dr. Al-Mefty, you see that biomechanically, there is no way to fix unilateral. The other side you move, this will fail. See? Because this say that has to be bilateral. In the great majority of the time, in your case that I saw, and the guy came and fix more medially here. See, it's like bilateral. You see?
Yeah.
When you fix unilateral, will fail. Your head will be like this.
No,
I don't know how you can get to keep the patient in anatomical position.
Call it
without halo.
Call it whatever you want. The end of the fusion is from the occiput to the C1 lamina to the C2 lamina.
Yes.
A solid bony fusion.
Yes.
Built
yes.
on a bony strut and whatever else might promote good fusion. So the head on the neck is fused. It's no longer a matter of that joint on the left or that joint on the right. You achieve a posterior cranial cervical fusion. The only thing we're saying here is the instrumentation. The instrumentation at the beginning till the fusion get a hold, it's adequate to be on one side if the other side fully intact.
But when you are planning to do the problem, for example, in chordoma, you never know how much bone you need you remove. You never know how much bone will be in the end. Maybe you're planning to say, oh, I remove just the condyle. But you start to drill, you see more bone, you go there, more tumor, and you go remove and move and move. It's happened with chordoma, not meningioma. Happens with chordoma. You never know. See. In the incision, your planning when the patient that you think that will need fixation will be different. It's not we're not making the same incision. If I think that I need fixation at the same time, the incision will be different. It will not be like this small straight like this. It will be a little bit larger to have more space in the middle. The way you can put you can do the stabilization.
My golly,
or you do the same
you're
one.
Good. You are good. You know what you're talking about, and you're thinking of everything. Yes, indeed. When we're doing chordoma, that the fusion is gonna follow, the incision is no longer a retro small mastoid incision. The incision cut across and more trapezoid, and the picture are into the many publication to the midline. So one could do even bilateral fusion.
The midline
available.
Fixation.
Now, a warning on this. That's how I did it. That's how I like to do it, and that's what I think it's a beautiful way to do it. If a spine man come in, if
they
you
take
want
everything
the spine
out.
man, the spine man wants a prone position and midline incision.
No.
If you're a plan that your spine man do the fusion, then make a very far lateral C incision, like you say, behind the mastoid, So he could still come and do a prone position with a straight line midline incision. And we did that.
Yeah, you can use the same lateral move,
Yes.
the skin flap lateral, and you have this interior part. Do you remember the publication about the rheumatoid arthritis?
Yes.
The incision was coming here in the midline.
Yeah. Yeah.
Yes.
Yes. Yeah.
This is what I'm talking about.
Yes.
When you're planning to do the fixation, you go the midline. And you stabilize bilateral, not stabilize unilateral.
You could stabilize unilateral. If you need to stabilize
In the
bilateral,
midline.
you do.
No, I'm not talking about bilateral screw. I talk about bilateral stabilization from the head. Okay? It's not
The bone
one
infusion. Yeah, okay.
Yes, yes. It's not one small piece of bone here, one small screw here. It's
That's
in the
correct.
middle here. See, from the same side. Yeah.
Yeah.
We are saying the same thing.
Let's hear the spiny guys. Please, Andre, please, Koji. I'd like to hear you guys, the guys who has experience in spine fusion.
Yeah, Koji, please come in.
Thank you, Professor Al-Mefty. Thank you. Of course, if the bone resection is too hard, it's too huge, and causing instability, you need to think about stabilization. I think it's the more important. It's a very good exam of the CT scan previous to the surgery, and depending on the patient's anatomy, the size of pedicle, the bone quality, you have several kind of stabilization. Of course, for my opinion, the pedicle, the C2 pedicle support is the best support in the craniocervical fusion, but sometimes it's not possible. When I put a screw in the C2 pedicle, in general, I try to palpate, to elevate the pedicle by the epidural space and touching the medical aspect of the pedicle, I pull the screw. But sometimes that is not possible. We have another techniques using the lamina of the C2. Of course, I can include the lateral mass of the C1, and if have not a good support in cervical, we need to go to the C2, C3, C4 lateral mass, or to put some screw to have a very hard instrumentation. But as Dr. Al-Mefty said, fixation is one aspect of the stabilization. The more important is to put a very good bone quality of something like the ribs, or have the good bone to take a great fusion after some months. Concern about the bleeding, the blooding of the venous plexus in the craniocervical junction, as Dr. Pauly said, as Dr. Al-Mefty said, the more important is not to go inside the plexus. In general, I try to do a dissection very close to the bone, and detach. You have if you do this detachment, you have a thin layer of tissue between the periosteum and the plexus bone. If you can keep the plex intact, generally you have the good control of the bleeding. I think that Dr. Andre have another comments about this kind of stabilization and fusion techniques.
Please, Andre, go ahead.
Thank you for the opportunity. Well, what the fact is that instability is not black and white. If you remove a lot of condyle, you have an increase of range of motion after surgery. There are many biomechanical studies that it's not necessarily unstable, but you increase the range of motion, and if you resect it more, you need to fixation, because at some point it will lead to pain or deformity or even neurological death. And when you decide to perform an occipital-cervical fixation, what we know is that from literature and from our experience, it's not necessary to include C1. You can include, but it doesn't increase too much the strength of the fixation. You have to include the occipital and C2. When you have to go down, if you don't have a good fixation at C2, you go down. Or if you have subaxial pathologies, for example, if you have concomitant stenosis in C2-3, you have to go down. C2, the pedicle is the strong fixation, but you have other options such as laminar screws, bar screws, and these are very useful options for children because the pedicles are too small. Then you can use the lamina. I have some cases of unilateral fixation, but for sure, the fusion and the stabilization, it's much more with bilateral because the occipital-cervical junction is quite mobile. For malignant tumors, unfortunately, we don't achieve fusion because most of the times patients die or go to radiotherapy, for example, in metastasis, in spinal metastasis. But for not malignant tumors, we have to be very aggressive and to put bone at this region. I like, especially in children, to use ribs because they are long, and then you can put in the occipital skull and at C2, and fusion is very high using ribs. Regarding concerning about post-operative the use of halo or brace, what we know that it's not necessary if you have a very stable fixation, but for there are some challenge cases like patients with severe osteoporosis, or that you cannot have good fixation in the occipital bone because the dimensions of the bone is too thin. In such cases, it's interesting to use a halo or to use a cervical brace. But if you have good screws at the occipital bone, good screws at C2, bilateral fixation, generally you don't need to use any post-operative halo or brace. Is that we know about occipital-cervical fixation and tumors. And another point is that I don't like to fixate patients in lateral position or in three-quarter of prone positions, because small changes in the head position are completely disabled after surgery. Patients stay like that. So once the instability it's not so acute, sometimes it's better to operate the patient, remove the patient from the position you operated. Okay, I have to go lateral. Remove the patient, put it prone, make sure that the head is perfect with the floor, the head is perfect with the body, and then you perform the occipital-cervical fusion. We receive some patients fixated like that. So you have to remove the rod, sometimes to break the bone bridges and to reposition the head. I think it's possible, but I really don't like to try to fixate someone in lateral position. It's possible, everything.
Thank you, Andre. I do like that. See,
Yeah.
if I do fixation, I do the second surgery.
Maybe if you have some eye problems, then you can.
Yeah, Dr. Al-Mefty will kill us, but it's okay.
Okay.
Dr. Al-Mefty, let's ask you something. Do you have a case that the chordoma invades the graft, the bone graft? He's here.
Yes, we do. And one is reported, and I've seen it more than time. The chordoma cell, it's a, somebody's going to have to understand the biology of it. It's worse than corona.
Yeah, let's ask you.
It's a grow on everything. If it touches the skin, it will grow on the skin. If it touches the tongue, it grows on the tongue. If it touches the graft, it grows on the graft. If you take a fat and to touch the fat in the abdomen, it will grow on the fat of the abdomen. What that means? What that means? That right now everybody talking about endoscopic chordomas. And endoscopic chordomas, you know, you have to in and out remove that endoscope so you could see the 3 depths and still have a clear vision. And this, the whole mucosa back there is torn down. So I will expect that the implantation, the seeding of the chordomas on the nasal cavity and the maxillary and the nose and the lips, we're gonna see a good number of them because
Yeah,
I've done the transoral, it grown on the tongue. Whatever that grow you do, it might grow. So you gotta have to protect and coat the whole surgical field.
yeah. You published this. Remember, Canon in the teeth, no?
Yep.
Implantation in the teeth.
Yep.
One question to Dr. Al-Mefty and Dr. Andre, maybe Dr. Osorio can help us here. If you do surgery and do the graft fixation, the craniocervical fixation, or any kind of fixation, how long you wait to send the patient to radiation therapy, to proton beam? The radiation in the post-op can be worse, can be problem for the fixation or not?
The question for me?
Yes, for you, for Dr. Andre, for Dr. Osorio.
Somebody else has to more knowledgeable or smarter about the effect of radiation on fusion. But chordoma is serious. As soon as they could heal and be scheduled for proton beam, they went to proton beam. I have not, this never became an issue that early radiation has interfered with the fusion. I don't know, as somebody more than I am, that has not come as an issue in the patient I treated.
Dr. Andre?
I don't have experience with proton beams, but I can talk in general words about fusion and radiation after tumors. For example, if you are dealing with malignant tumor, metastasis, for instance, you don't need to care about fusion because you won't have fusion. It's a stable pseudoarthrosis. You get just a stabilization without fusion. If you were treating, for example, another tumor that you have to have you need to be fused, you have to wait at least 3 months. But if you go to radiate, generally is malignant disease and you want to fusion. So you don't need even to put bone graft if it's malignant. It's very questionable if you have to put bone graft for malignant disease. Because radiation...
Dr. Osorio or Dr. Aversa may have some. Osorio, please.
Yes, we don't have a proton beam machine.
Any kind of radiation.
Any kind of radiation. Only, you know that the arthrodesis will produce in 6 months to 12 months. And really, for the arthrodesis, is really, it's not a good thing to have a radiation immediately. But if you have a patient that you need to support with some screws, they support between. You have the necessity to do the irradiation, and you have to irradiate the patient with a malignant tumor fast. Not you have not to wait 6 or 12 months to do that. I think that the initially with the structure of the screws, you have some stabilization, and you can do the irradiation.
Very
Antonio?
good.
Antonio?
Let's hear Antonio with this beautiful background just behind him.
This is preparing the team for the March 12-22. It's always nice to see the presentations of Dr. Borba, and thank you so much for sharing your tremendous experience. And always nice also to learn from the panelists and from the comments of Professor Al-Mefty. I just want to ask Dr. Borba, Dr. Al-Mefty, for those uncommon cases that midline foramen magnum meningiomas with the compromise of the 12 bilaterally. What's your policy? What would you do in these cases?
Bilateral 12?
Yeah.
I had a case, but post-op, not pre-op.
It's a terrible situation. When you are concerned about a bilateral lesion, what you do, what's your policy?
Depends of the side. Sometimes it's more from one side to the other side. If the tumor is more on one side, you have to follow the tumor from one side to the other side. If the patient had in the pre-op bilateral 12, maybe this patient needs tracheostomy. Maybe the patient, or sometimes, or gastrostomy, please, not tracheostomy, gastrostomy. See, maybe that. But in general, it's not totally in the midline. You don't have any room. How
Yes,
there is a room from one side that you can go. You are talking about to come from the mouth, yeah? You want to come from the mouth? Oh, Antonio, please, Dr. Mefty, he's changing his mind. He's talking too much with Juan Luis Gomez Amador. Antonio, ask me about the radiation. How long you wait to send to radiation patient with you do some kind of fixation or craniocervical junction? What's the protocol in Inca?
I don't know if there is a strict protocol, but I think I'm used to wait at least 3 months. I think it's a good time for healing the bone.
So we are almost reaching 10 p.m. here. I'd like to listen the final remarks from Professor Al-Mefty, Professor Borba, and all the panelists who wants to make any other comments.
Dr.
Professor
Al-Mefty,
Aziz.
please. Oh, this is so quiet.
Yeah. Professor Al-Mefty, please, your final remarks.
Aziz is so quiet. Aziz is so quiet because his team yesterday went out from Copa do Brasil. See, Palmeiras. They lost for a small team from North. Not small team, not so famous team. It's different, not small. Go ahead, please.
I think it's the most critical part of the foramen magnum, especially if we were talking about meningioma, and just didn't have a chance to emphasize it because of the beautiful surgery Borba has shown. The anterior spinal artery. My golly, do anything, but do not risk the anterior spinal artery, because those people live, but they cannot move below the neck. The anterior spinal artery. If we've been left after these 2 hours with one word, it should be the anterior spinal artery. And I want to hear what Professor Aversa was trying to tell us. You know, I heard Professor Yazergil many times so scared of bilateral 12 nerve. I never seen it, and I hope I will never seen it. But obviously it's something horrible because the tongue sits in back of the throat. You can't talk, you can't swallow, you can't hardly could breathe. So what you're trying to tell us, Antonio, please, how do we avoid or how do we manage a lesion that involved the bilateral 12 nerve, or you ended with bilateral 12 nerve deficit?
Fortunately, I have only one case, sir. It's a it's a terrible situation, and you need the gastrostomy, and it's completely incapacitating situation. So in those cases of the midline tumors that we are concerned about the bilateral involvement, maybe you should be more conservative and try to preserve one if there is function in that other side that probably is involved but not totally paralyzed.
And how do you treat it if you run into patients with bilateral 12? Is it worth it to do a nerve transplant? Take the facial nerve and put it on the 12?
I don't know, sir. Actually, that patient with the cordon was a very aggressive tumor, and the patient had many clinical complications and died a few months later. So, but it's a terrible situation. I hope I'm not going to have any other one.
Very good. So, Dr. Barba.
What?
Your final remarks.
No, not. Dr. Colley want to talk. See, I just saw what your Dr.
Professor
Colley.
Colley, raise your hand.
You sent his table to us. You are invite everybody to the dinner. I just saw you send a WhatsApp with your dinner. See.
I told you that was wrong message. Yes, but
you're not invited.
I had one case of bilateral lesion of the 12th nerve, but it was by trauma. The patient cut with a knife both hypoglossal nerve. I did suture of both hypoglossal nerve and the patient improved. Maybe a transposition of the facial to hypoglossal can work. Facial or even other motor nerve.
But in the neck?
Yes, in the neck. She cut with a knife, both hypoglossal nerves.
Nice guy. Okay. Maybe you have time to go home. Stay home. We're going to dinner.
It's time to go to dinner and sleep.
Yeah, dinner to Dr. Colley's house. Let's see if he can show the table to us, Dr. Colley. He will show the table, very nice wine and cheese. Okay, thank you, Professor
It was
Al-Mefty.
from one friend from my medical school. Not me.
Was not for you. I thought the wine was so expensive that I saw the table. I couldn't
Yes,
Dr. Colley. You not spend so much money in this wine.
So
okay.
We had the great pleasure to have Dr. Barba this evening, and we hope to schedule Dr. Sebastian Froelich for any other Al-Mefty series in few weeks. We're gonna give some market about this new data for you. So thank you very much, everyone. Thank you very much, Professor Al-Mefty, Professor Barba, and all the panelists to be with us this evening. Thank you very much for all the audience too. Thank you.
Thank you, sir.
Thank you.
Thank you.
Bye-bye.
Thank you. Thank you.
Good night. Thank you. Thank you.
Thank you.
Dr. Colley.
Parou de gravar, agora o Paulo Cali vai falar alguma coisa, não é possível.
Doutor Colli,
Oi, Márcio, fala.
doutor, esse caso dos dois hipoglossos, como que ficou a carótida?
Não aconteceu nada.
Pô,
Isso
o
aí
cara era
foi.
bom, hein, cara?
Então. Talvez a faca não cortasse nada, mas isso aí foi que nem uma vez que eu tive uma paciente um paciente masculino que levou uma podãozada no pescoço, na parte posterior do pescoço. O facão parou na dura mata.